You cannot substitute the use of a mask for physical distancing. You cannot substitute the use of a mask for testing, finding cases, for contact tracing, for quarantining cases. So all of this has to be done together as part of a comprehensive approach. But again, we do support leaders in taking those decisions and using this as part of the approach to tackling COVID-19.
Thank you very much, Dr. Van Kerkhove. So the next question goes to Simon Eteba from Africa Today. Simon, could you please unmute yourself and go ahead?
Can you hear me?
Very well, Simon. Please go ahead.
Thank you for taking my question. This is Simon Eteba from Today News Africa in Washington, D.C. More than 720,000 people have contracted COVID-19 in Africa, and 15,000 of them have died so far. South Africa, one of the richest countries in Africa, with more than 364,000 cases and 5,000 deaths, now accounts for more than half of all the cases in Africa and over 30% of all the fatalities. In fact, there are now more than 500 new cases in South Africa every hour, or more than 12,000 every day. Yet, South Africa was among the first countries in Africa to impose the WHO recommended lockdown, shutdown, wearing of face masks, hand hygiene, contact tracing, and treatment. I was wondering, what else can South Africa do right now, and what is South Africa missing? Thank you.
So I can perhaps start, and Mike, I'm on. Yeah. Mike, you might want to supplement. So I think, Simon, that's a very good question, and it's a complex one. And if we look at all of the measures that South Africa and many countries have put in place, it is about being consistent and persistent in applying all of these measures. We do know in South Africa, a lot of the outbreak began in some urban centers, and now the virus has moved into more rural areas, affecting different populations. We know that when a virus enters a country, it doesn't enter uniformly across the entire country. It tends to start somewhere and take root. And all of these measures do need to be applied in different aspects of it. I think what South Africa is doing, and they have very strong, a robust response. The leadership in taking a comprehensive approach, engaging communities, looking at a data-driven approach. We engage quite closely with South Africa through our regional office, through our international networks, to be able to apply what they are learning, to feed back into the response that they have themselves. And it is about continuing to apply all of these measures. They will bring this under control. As all countries will, in applying all of these measures, and stay vigilant, stay strong, continue to engage with communities, all levels of the community, listen to the community, feedback into your response, and adapt. Be agile and adapt. Mike?
Yes, and we are, I know Dr. Tedros has been in touch directly with very senior colleagues in South Africa, and we're working with our regional office on providing surge support, further high-level technical assistance to support South Africa in its response. I think we also need to remember that South Africa got its first cases quite early, and it's in a later stage of development of this pandemic. And the disease, when it came into South Africa first, tended to come into at the beginning into wealthier areas, and now has become very much established in poorer areas and townships and rural areas. So therefore, South Africa is experiencing that acceleration. But it's not accelerating any faster than many other countries in Eastern and Southern Africa, all over Africa. In fact, the South Africa numbers may be large, but they've only increased about 30% in the last week. But if you look around the region, in the same time, although the numbers are smaller, Kenya's increased 31%, Ethiopia 26%, Madagascar 50%, Zambia 57%, Eswatini 32%, Zimbabwe 51%, Namibia 69%, and Botswana 66%. And even though the numbers in those other countries are smaller, I think what we're starting to see is a continued acceleration of transmission in a number of countries in sub-Saharan Africa. And I think that has to be taken very, very seriously. South Africa may unfortunately be a precursor. It may be a warning for what will happen in the rest of Africa. So I think this isn't just a wake-up call for South Africa. This really is, we need to take what is happening in Africa very, very seriously. Many of those countries exist in the midst of fragility and conflict. Many of them need external help and support. But what they need is much more support to community-based interventions and much more support to improving clinical pathways so people who are sick get adequate care. And as Sose has said previously, much more support to public health surveillance and being able to put in place the necessary early warning. So while South Africa is experiencing a very, very severe event, I think it is really a marker of what the continent could face if urgent action is not taken to provide further support. So I think, and we've seen this in other regions, sometimes this disease can take off very quickly, and sometimes in other situations it takes off more slowly and then accelerates. And it's difficult to understand fully why that is the case. But I'm very concerned right now that we're beginning to see an acceleration of disease in Africa, and we all need to take that very seriously and show solidarity and support to those countries who may now be experiencing increasing numbers of cases and deaths.
Thank you, Dr. Ryan. The next question, it might have to be the last because we're coming toward the end of the time allotted, goes to Helen Branswell. Helen, can you unmute yourself and go ahead?
Hi, thanks very much for taking my question. I apologize, I missed the beginning of the briefing, so you may have covered this, but since Dr. Fall is there, I would like to ask if he could give us any kind of a sense of how things are going on the ground in Equator Province with the new Ebola outbreak. Numbers are available from the Ministry of Health in DRC, but we're not really getting much in the way of detail on how well or not well the containment effort is going. Thank you.
Thank you, Ellen. Good to meet you again. I have been interacting so many times around Ebola in North Kivu. And as you rightly said, this new outbreak is happening in Equateur, which is a different context with very limited resources and difficulties to move from one area to another. You have to move by boat, by helicopter to make sure that you can implement the right intervention. So in terms of operation, we have now 7 health zones affected, although 6 are only active right now. It means decentralizing operation to all those health zones, making sure that we have all the necessary capacity in terms of investigation, in terms of isolation, treatment, contact tracing, and vaccination. And so we have a good team on the ground composed by Congolese WHO staff we already had in Congo, some from North Kivu, others from Kinshasa, and a number of partners like MSF, UNICEF, IFRC working around various pillars. So we still have some challenges in terms of alert, mainly alert related to dead body, because it's very important to make sure that our surveillance pick up all the alert, not only from the health facilities and alive alert in the community, but also dead body. And so we are scaling up, still have important gaps in terms of operation because of the difficulties to move around the area. So we continue monitoring the situation and having a daily briefing from the ground and making sure that all partners scale up in the area of responsibility. So it's challenging in the context of COVID because in the capital city in Kinshasa, many people are focusing on COVID-19. So making sure that they don't play Ebola is extremely important. We need also from the national side to scale up operation in all areas. Thank you.
And if I might add some of the numbers, Ellen, we had 3 new cases over the weekend. We now have 60 Ebola virus cases, with 56 of those confirmed, 4 probable, including 24 deaths. I think, and as Sose alluded to, the worrying aspects of this response in that there have been cases in 21 health areas across 7 health zones. So while the numbers are very low, the disease is quite dispersed. And 5 of 7 of those health zones have had cases in the last 4 days, which means the disease is active, it's not old. So what we have is active disease in 5 health zones across a wide geographic area. Again, worrying is that there are still 9 cases who are still in the community, and there are real challenges in terms of community engagement and convincing people to come for care in Ebola treatment centres. And of the overall period in terms of exposures, and again, this may go back to the whole issue of case finding and contact tracing and getting the information you need to know where and what the transmission factors are. It is interesting to me that in this case, in the most extreme situation of logistics, probably in the world, the data that comes in daily from the surveillance teams, tells us that for the people who've been exposed over the last 21 days, for example, the exposures, but over 1 in 3 people have been exposed at a funeral event. Just over 10% have been, 11% have been exposed through nosocomial or in the healthcare system, and a lot further number of people have been exposed in a family context. So the information you glean from case investigation and contact tracing tells you who's at risk. And we're able to say for a very remote part of Congo, the big risk factor in this particular clusters of cases is funeral practice, and we're working very closely with communities then to really work with them on the funeral process and on engaging with them on how to make that practice safer. It is very hard to engage in generalities. When you work with communities, you must be able to engage on specifics. Getting good data from case and cluster investigation gives you the specific data that allows you to identify the risk factors and then engage positively with communities on how to reduce those risk factors. This is epidemiology and public health in action. If we can do this in a remote part of Congo, if we could do this in the middle of a war zone in North Kivu, we can do this for COVID-19. It is not impossible. Many countries have demonstrated that all over the world. So I think even though we don't have perfect data from the field, and Sose can speak to some of the challenges we face logistically and operationally, the fact that we have these data, we know where our problems are in the field. We know where our hotspots are. We know what's driving transmission in those communities. And that allows us and gives us the basis to intervene and to make a difference. So while the situation in Congo remains of concern, what reassures me at the moment is that we're improving in community engagement. There are many partners on the ground. And again, we'd like to thank our partners, particularly in the Red Cross movement and others who once again are working with local teams in terms of safe and dignified burial, our colleagues in UNICEF who are working on communications, our colleagues in the UN system working on coordination, the World Food Programme working on logistics and support to base camps, but most of all, the frontline health workers of Congo, the Congolese doctors, nurses, hygienists, community engagement specialists who make up the vast majority of the front line in this response. And again, our thanks to the government, the Ministry of Health and the Institut National de Recherche Biologique, INRB, for their leadership in this response.
And thank you, Helen, for your question, which really ties together much of what we have been trying to get across today. And now I'll hand it over to Dr. Tedros for final words.
Yeah, thank you. Thank you to all who have joined today. And look forward to seeing you. I think the next will be on Thursday. Thank you.